Hello, I'm Mally Schansfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Welcome to a presentation and question and answer with Dr. Stephen Buchanan. In our CE webinar today, we will be focusing on the most recent advancements in technology that are influencing endodontics. The focus will be on 3D microscope, guided surgery, and multisonic ultra cleaning technology. Upon completion of this CE webinar, attendees will be able to learn about recent technological advances in root canal therapy, understand the objective of 3D microscopes, become familiar with the aim of guided surgery in endodontics, and understand the benefits of multisonic cleaning, ultra cleaning technology. Before we get started, I would like to invite viewers to use the question box in your control panel to ask any questions. Your questions will be answered via email after the session. Also, associated with this presentation is a free CE quiz. At the end of the webinar, we will email all attendees instructions on how to access the CE quiz, or if you're viewing the recorded version, you can access the quiz on our landing page. I'm pleased to introduce our guest for today, Dr. Stephen Buchanan. Dr. Buchanan currently serves as an assistant clinical professor at the University of Southern California School of Dentistry and the University of California at Los Angeles School of Dentistry. He also maintains a private practice limited to endodontics and implant surgery in Santa Barbara. Dr. Buchanan is nationally and internationally known as an expert in new technology in endodontics and is the founder of Dental Education Laboratories, a hands-on training facility in Santa Barbara, California. He is a diplomate of the American Board of Endodontics and a fellow of the International and American College of Dentists. Dr. Buchanan, we turn the webinar over to you to learn more about our topic for today.
Thank you so much for inviting me to give this webinar. This is a really exciting time in endodontics. I've been doing this specialty for 4 decades now. It's surprising to me even. And we've seen an acceleration in the rate of innovation in our specialty, as we've seen in all of dentistry. But the digitization of dentistry and endodontics is changing everything. And it's not just digitization, it's bringing in some of these high-tech possibilities from outside of endodontics, like dynamic guide. So let's get into it. We're going to talk about cone beam CT imaging. I want you guys to think about it in a broader sense of not the system that you sit around and try and think, should we take one now and not take one? You need to take one in all your cases. Then some of these you're going to need to take extra volumes during and even after therapy. We're talking about the advantage of heads-up magnification. It's changing our use of magnification. It takes all the deficits of microscopes and makes it possible to put the microscope in any position in the patient's operative field and still see perfectly without having to put your eyes on eyepieces. That's transforming my physical experience of endodontic practice. We show you dynamic guidance. The worst problem we've ever had in endodontics is cutting an access carefully and accurately through a calcified pulp chamber. It's such a great opportunity to hurt the tooth, to look, as you're an endodontist, look like you're hacking away at it and finally found the canal. With dynamic guidance, we now have these cases managed with an elegant ease that has no anxiety provoking aspect to it. So that's changing my experience in endo. And then finally, probably the most exciting technology is multisonic cleaning. And of the triad of shaping and cleaning and obturation, cleaning is actually the final one we've really come in to solve. And there's some amazing results we're seeing clinically. So I want to share that to you as a finish. So let's get into it. Periapical films, our 2D periapical films, have been the standard that we've depended on to make our diagnosis and treatment planning, little realizing that at least 30% of all the pathology that our patients have around their teeth are not going to be represented. And so now that we have CBCT imaging, it's a whole different story. If I show you let me put my cursor down here. If I show you the same tooth in volumetric form, we see the straight-on view on the left and the mesial view on the right, and realize that even though I can see a periodontal ligament on the 2D conventional film, which would indicate that there's bone next to the root end, we can tell in the CT imaging that it's a 4mm lesion there. This is primarily because the root is outside the cortical plate. Most of our patients now are having their orthodontics without 4x extraction to get that beautiful full arch form. It looks great, but what it means is if they didn't expand their palate, then these roots are outside the cortical plate. So we're going to have more challenges in diagnosing from conventional radiography than ever before. So it's a godsend to have this. We've often thought that it would be so beautiful if we could do root canals and understand everything about the anatomy before we got in there. And we kind of said that because it's, you know, like an unrealizable dream. But now that's the age we're living in. Is I don't go into root canals without knowing where every primary canal, every branch, every fourth canal, even every lateral canal in most cases is before I even touch the tooth. And that's fun. Here's a case that the patient had odd symptoms. It was sensitive to biting, pressure, and percussion, but the pulp was vital. We did pulp testing. There's not even a hint of a periapical lesion around the roots. Let's see how different the cone beam CT imaging is of this. The palatal root, which you cannot see because of the overlay of the other roots. Actually, overlaying anatomy is one of the greatest artifacts we have in conventional radiography. It shows in CBCT form that the root is almost cut entirely in half by external resorption. This tooth has no chance of being saved. So normally we would be spending an hour in this case, and before we found out that it couldn't be saved. Cone beam CT imaging, my cone beam machine pays for itself every month just by showing me cases like this that won't be successful, so I don't start them, so I don't lose the money on those cases that inevitably happens. So it's changing the way we practice in financial ways as well as in procedural ways. Many of these cases, obviously, we see the resorption in the cuspid in this image, but we don't know how far it is. We don't know if this is something that could be surgically repaired and go on to use this tooth as a healthy functioning member of the dentition. But we look at it from the side and we realize, oh my gosh, there's a huge defect right at the most aesthetically challenging part of this tooth, supporting the soft tissue over it, and we know that this has to be replaced. We also see one more time how this root is literally outside the cortical plate, and there's maybe a 0.5 millimeter of bone on that buccal surface. And here's another view. This is an interesting case. This is the first time I started thinking that I should be taking CBCT volumes on all the cases I treated instead of the ones where I thought it was important. And I think most of us that get into cone beam imaging go through this process of finally understanding that the only way you can tell if you need a cone beam CT image is to take one, look at it, and see if there's anything that surprises you. And so that's a sarcastic way of saying you just need to take them in all your patients. Cone beam CT imaging is such low delivered radiation dose that you're going to be irradiated more by flying, and this is proven. I've talked to radiation physicists. It's not like just a little, urban story, but you're irradiated more on an airplane flying from LA to New York than taking one more turn of the cone beam CT machine. So there's no radiation hygiene reason not to take a cone beam CT. And if you have one in your office and your patient can't afford it, I'm going to give it to him for free because it doesn't cost me anything to run the machine. It gives me more information. I'm going to do the case quicker, and this is a great example. The second molar became irreversibly inflamed. I can't see anything about the anatomy. I see a block of root, maybe a pulp chamber. I can't tell if this has 1 or 5 canals. So I decided I need help on figuring this out before I get inside there. Turns out it is a fused root. There's only 3 canals. And then I look at it from the buccal, making sure the slice is exactly through the canal, the canals in the buccal root form. And what I see is a common buccal orifice, the canal that splits into 2 canals, the mesial buccal and the distal buccal. They join and exit together, but I can see this accessory canal coming off that, and I would guess that there's something maybe here or here along the sides. We finish the case, and voila, it looks exactly like I knew it would be when I got into it. So really complex cases that used to require a lot of detective work, we don't have to do that anymore. We go in with an intention, knowing all the problems we're going to have. We solve for them in our treatment plan before we even cut an access in the tooth. And then the execution becomes a matter of predictable outcome instead of, I hope I can find everything. I hope I can figure this out. This is a case I had to do as a live demonstration. It was the only upper molar that came through my practice. So I'm a little intimidated with the curvature here. My first question is, does this have a fourth canal? I look at the axial view. One of the happiest moments of using a cone beam CT is looking at a horrible root like this and realizing you only have 3 instead of 4 challenges to treat it. And then looking at the buccal view, again, putting the cursor through, I can see exactly the curvatures in this obvious dimension. But looking at the distal, the mesial view of the distal buccal root, we can see that there is a hidden buccal curvature there that looking at this view here, the root looks relatively straight. So again, it's all about not being surprised anymore. And once we know what the anatomy is like, we can make decisions immediately and execute those shapes, clean them and fill them. This is a case where we weren't sure that if this was an endodontic lesion. We thought more likely it was a sinus, mucocele, or some benign growth up there. So I scanned it before I referred the patient to an ENT. And when I started looking through the slices from the one that represented the same view we see in the 2D film, start slicing back towards the palatal, we realized this is actually a lesion from the palatal root, and because it's in the sinus floor, there's no conventional lesion that shows there. And once you start doing CBCT imaging, you realize that we never realized that you have to have bone around a root end to have a radiolucency. And when they're in sinuses or outside the cortical plate, it requires volumetric imaging to tell what's really going on. There, it's an obvious lesion, but when we look at the pre-op on the left, looking at the root tip, the palatal root tip through that lesion, the halo of the lesion, I can read a PDL there. So we'll get fooled all the time, and in this case, we know exactly that it's basically a cystic sac encapsulating the infection coming out of that palatal canal. And after you learn that you're going to probably want this for every single endodontic case you ever treat, you're then going to take the next step and find out there are cases where you're going to have to actually get another CBCT image set in the middle of treatment. For instance, if you can't find a fourth canal. This is another live demo case. Unfortunately, this one did have 4 canals, as shown on the shallow distal conventional view. If you ever want to know for sure if there's a fourth canal, put a file in the MB1, take a distal angle to back to forward, and throw the mesobuccal root in an off angle, and then you're basically looking for centrality. You want to see, is that file in the MB1 centered in the root surface, and if it's even slightly off center, you know by definition there's another canal in there. Now, better than that is having the CBCT, which I did in this case. But regardless, I was looking forever and couldn't get into it. So finally, frustrated, not having any success, I'm thinking, what am I going to do to get in here? And I hadn't considered it before, but finally I realized if I took a cone beam CT volume right now, I could see where I cut. I could see where the canal is and maybe connect up and find the relative position. So here is, it's a little blown up, but we see an axial view of this tooth after I treated the distal buccal and the palatal. So when I'm doing a 4-canal molar, if I can't find the 4th canal, I'm going to go ahead and treat the distal buccal and palatal roots. I'm going to bring them back for a second appointment and look one more time. Many times having a fresh outlook, not being tunnel visioned in like you tend to get. I'll open up an access and go, oh my God, it's right there. And it's a different place than I was looking. So what I do now is if I can't find it on that first visit, and it's usually an hour and a half or 2 hours, I bring them back. We scan them before we bring them back in the operatory, and here's what we see. We see the MB1, we see the MB2. We look at the axial view, or the mesial view. We see the mesiobuccal 1. It's instrumented now. There's my trough looking for the mesiobuccal 2. Here's the MB2. I'm only a ½ millimeter away from it, but it's in the scariest direction. It's in the mesial palatal. It's right on the path to that frication that we never want to perforate. So seeing this, I go back in. It takes me literally, and by the way, you want to look at the buccal view and make sure this angular path is, or this path to look for MB2s is in a mesial apical direction, never straight apical, or you'll perforate the frication. But once we have this and we know we're heading the right direction, can't find it, do not head straight down from the pulp chamber floor. But once I know that it's a ½ millimeter away in which direction, I literally just touch it with an ultrasonic tip, and suddenly I've got tug back with my Explorer. I put a file in there, and we're in one of the hardest kinds of cases. And intra-treatment CBCT imaging is the key to this and solves for this really challenging issue we have. So the next technology I'd like to explore with you is heads-up magnification. This is technology that comes out of neurosurgery and ophthalmic surgery. A company named True Vision makes this, and I've been using it for the last 2 years. I honestly don't ever want to look in a microscope ocular again, because it requires me to be in an awkward position and in a very static situation for hours at a time when I'm doing long procedures. And I have an iWatch that will not let me sit in the same position for more than 20 minutes without telling me to get up and move around. And having oculars on a microscope is the antithesis of that. And I have had 4 back surgeries. And even when I didn't have any impingement, at the end of the day, looking at a microscope, I felt like the 100-year-old endodontist. Now, when I sit back in my chair and I look up, it's natural. It's a better position. I can make small movements in my body. My circulatory system is going to be much better served. And it's literally changed the whole physical experience I have of doing endo. I have more depth of field. I have an unlimited positioning possibility of the microscope. I can put it over their chest, aim it up at their maxillary teeth, and cut an access cavity with no mirror in an upper tooth. I can put it to the side of their face and see the stop of an instrument coming down in a perfect right angle, so there's no parallax errors in my length control. It's just everything's more relaxed. I don't have to look into oculars. I sit back, I look up at the screen, and instead of looking at an ocular and I have to be within a millimeter of position, I look up at an 80-inch screen in my operatory, and I'm a little extreme. You don't need an 80-inch screen, but an orifice up here is like 1.5 feet wide. So suddenly magnification becomes even greater in the displayed amount of magnification. So heads-up visualization for me has been a game changer, and I'm 100% convinced it's going to extend my career at least 5 to 10 years. And I love what I do, so that's everything for me. So just kicking back. Let's talk about dynamic guidance. The worst problem in my opinion, in specialty practice is calcified teeth. And I've often said if I never had to do a single calcified tooth the rest of my career, I'd probably live to be 120 in practice till I was 90. Calcified teeth are so hard, they will wreck a whole week when you have one of them go south on you. So dynamic guidance has been an amazing answer to this huge problem. We had cases like this, a severely tipped second molar. It's been restored with a brilliant 5-unit bridge 2 months before. The tooth becomes necrotic, and this whole restorative effort is going to be lost if I can't find the canal. There's no pulp chamber. The crown is 16 millimeters high, so I'm going to cut 16 millimeters into this tooth before I have a clue as to whether I'm on track to find the canal or not. And so as it is now, you give up a little bit of heart muscle. You spend as many hours as it takes to fuss your way through it. But these can be done, but there's nothing pleasant about it. If you don't botch it, you just feel relieved. And it is a really good opportunity to look a little hacky if you're looking here and you're looking there before you find the canal. So what's the answer? Well, my dad was a control systems engineer for missiles. He was involved in the Red Eye, which became the Stinger missile. And so you might say that genetically I'm programmed to want to have some type of help and guidance. And as I said, it's changed everything about endo access in difficult cases. And if you're an endodontist or GP that does endo and implant surgery, you get a twofer. So I've always been a big fan of drill guides for implants. I've been doing implant surgery for 15 years as a service to my patients and referring dentists. When I find out that a tooth has a poor prognosis or one that doesn't rationalize trying to save it instead of replacing it, you got to remember that an endodontist that does implants is the only unbiased opinion about whether they should have an implant or a root canal. But when I decide it doesn't make sense to try and save the tooth, they don't have to meet somebody new. They already have the guy that's going to do the implant surgery, all worked up. I have all the imaging, all the medical dental questionnaires. As I said, it's a service. But I'm coming into implants at relatively untrained compared to my endodontic training. So my crutch that helped me get perfect results every time from the very first implant I placed, and this is one I did for my most fussy prosthodontist in Santa Barbara. that he sent his assistant over to have an implant try me out, and model-based drill guide helped me put it exactly in the right position. So I love drill guides. It makes up for lack of experience. I tell my colleagues, when you start out doing implants as an endodontist, you'll probably expect what you'll accomplish in the first year or two, but you'll be a little surprised at what happens at 5 years. And like me, you'll probably have somebody refer you a 12 implant immediate full denture hybrid denture case. And while these aren't the case I prefer because they're so much work, being able to put 1 to 4 implants in perfectly with a drill guide is everything. So how do we use drill guides? Most of them come out of the implant business. We've been working on doing periapial surgery with them, and there's a difference between static and dynamic guidance. Static guidance is when you have a treatment plan you created in a virtual environment showing the tooth, etc. And off of that, you print or you mill a drill guide that snaps on their teeth. It has guide rings that the drills are operated through, and it's a static drill guide. So once it's made, that's it. You don't get to change it. There's some other problems. However, all the research on implant guidance and on guidance in endosurgery with static drill guides show that we're far more accurate. A lot of the implant surgeons, especially the young ones, don't think they need drill guides, but if you talk to Gene Triplett, who runs the Baylor program, he goes, they don't think they need drill guides, but I have to deal with their cases after they leave the grad program, and trust me, they need drill guides. So it's not any different for me as it is for the implant surgeon. Here is an experimental procedure I was doing using drill guides for apical surgery. You can see 2 well-restored posted teeth. Instead of trying to retreat through the tooth, we're going to just cut a very precise opening at the apices of both of these teeth and shorten the procedure, reduce the post-op healing, discomfort, etc. We can also make a drill guide for conventional access. This is my own second molar that had a cracked root, and we use it as an experimental subject. I've also made drill guides to use as a laser guide. This is one that I used to cut an access at the ADA meeting in 2015, and we hit the distal buccal canal perfectly. So guidance is good. The problem we have in endo is static drill guides are almost impossible to use for conventional access. Most drill guided drills are 10 millimeters longer than standard ones. We don't have the room. If you're putting an implant in, you're putting a drill on an edentulous space. You have 7 or 8 millimeters of extra room there. For endo, the tooth is intact, and it's going to be impossible to fit it in there. Plus, canals are so close together, you would have to have 3 to 4 static drill guides for every molar that had 1 for each canal, because there's not room to put the guide rings next to each other. So while there have been several authors that are saying that this is a good way to do it, we like guidance, let's prove that static drill guides can allow us to drill 7/8 of the way down this calcified blocked out canal and hit a canal exactly at the end. Great. But this drill is 30 millimeters long, and it wouldn't even fit in a maxillary central incisor. So we have to think of other ways to do this in static drill guides. Virtual reality, it's a lot of fun, but really nobody wants to practice wearing a bunch of headgear on their face. But let me just show you, this is a little bit Minority Report, the Matrix. There's my virtual patient. She's kind of a creepy, blonde, blue-eyed German gal. And when I put my hand up there, I'm going to choose the functions. And so that is a prototype, so it wasn't that easy to use, but nevertheless, this is the direction we'll be headed in terms of guidance. And this is an optically guided system. Shortly before this, however, at the Osseointegration Academy meeting in San Diego in 2016, I'm walking the exhibit floor. I walk around the corner, and all of a sudden, this challenge I've had with how are we ever going to use static drill guides in conventional endo is answered with a dynamic guidance system. So there is an overhead twin light system that's watching fiduciary coded patterns on my handpiece and on the patient's jaw. And so this computer system knows where my burr tip, drill tip is compared to every part of her anatomy in her jaw. And I literally watch the monitor while I'm doing the procedure. We'll see this in action. This is the target that comes up. You tell the computer where you want your drill path to go, and then when you get near that, it zooms up and shows you the blue dot in the center. That's the tip of your drill. You want to put that in the center of the target. Obviously, there's a tube behind it that angles, and when you're looking straight down the tube, your angle is correct. The green strip that goes clockwise around from 12 to 9 o'clock is telling you the depth, and whatever depth you program, when you hit the 9 o'clock position, that's when you're supposed to stop, and it does freak out until you quit. The accuracy of these is every bit as accurate as static drill guides. One of the greatest things about them is they do not require a guide. You don't have to have a longer drill. You can change your drill path treatment plan in the middle of the procedure. Because sometimes you put one implant in and you change your mind about where you want the second one to go. Same thing with accessing independent cases, independent canals, and calcified teeth when we're trying to keep it to a minimally invasive access size. So all the research is showing that it's great for implants. My colleagues, Charles Maupin and John Cotomy, are almost done with an accuracy study using this technology in endodontic access. So here's one of Charles, Dr. Maupin's cases. It's a central incisor with no canal in the coronal half. Obviously, it shows in the CT. You can see he's moving the handpiece and watching in real time. So we have an avatar up here of the tooth in our treatment plan target. Now he's got the angle of the drill perfect, and you can see the yellow band marching around to the 9 o'clock position as he drills deeper. And he was able to find this canal and have like a 1 millimeter opening at the cavo surface, which is definitely minimally invasive. I'll show you a couple of other cases. This is an implant case, previously placed implant in the cuspid position. This lateral is failing for structural reasons. I extract it, graft it with a PTFE membrane, and come back, and I'm able to snake a 3.5 by 15 millimeter Nobel active in here, just exactly between the implant and the adjacent natural tooth. And that just got restored and looks remarkable. We used to say you could never put implants that close together, but we can now. This is a central incisor, again, a lesion that doesn't show on conventional films. We see apically, it's there, and obviously we knew that because the patient's tooth is sensitive to percussion. There is no canal in the coronal 2/3 of the root. This is the fiduciary clip in place. That was me positioning the drill tip on a target so the machine knows exactly where it is. We find out the position of entry, and here's the first check film. Here's the second one, and this canal was intersected about 3/4 of the way up. There's the first file in place. I put the rubber dam back on, and we carry on and treat the case as any other root canal that actually had a canal in it. And you can see again a very minimally invasive access style, not a single ding on either side of the canal, headed straight for it, and the post-endodontic restorative result shows a total continuity. So that's a case I'm not only no longer afraid of, but proud of, because we can do that to a level we never could before. Here's one of Charles' cases. You see the programming for the drill path. He's got a drill, a virtual drill there, and he's just really rotating around in the X, Y, and Z axes. And he found this one in the last 3 millimeters. So we're doing micro endo in calcified cases. This is one with no pulp chamber. I made 3 separate openings. There's the file in the distal buccal canal. There's the burr tip headed towards the mesobuccal canal. I haven't gotten into it quite yet. Here's the first file in, the second file in, final case. And you can see we have only 2 openings, the mesobuccal and the distal buccal from this ovoid opening, and then the palatal through this separate opening. These smaller openings make it really easy to restore these ceramic restorations, leaving no evidence of a previous access. So I love this technology because it solved the worst problem I have. And here's one of my favorite cases of Charles. We look at all these really talented endodontists doing minimally invasive endodontics, and what I see is really small coronal shapes, small access openings, and almost never do I see the 3-dimensionality of his treatment. Obviously, Charles does a lot of irrigation before he fills the canal system. but that whole challenge is changing as we speak. That's the last topic we're going to approach. Here's another one, 3 separate openings. You can see individual pathways for each canal. And that's eminently doable. And you could argue that this tooth has actually no loss of structural integrity because we're making these separate holes. It's like kind of like putting holes in the rib in a fuselage of an airplane. You can cut the holes in the right place and lose a lot of weight and no strength. So we may be able to do root canals in the near future without weakening them one iota. I'll finish with on the dynamic guidance topic with this case that was referred to me at 10 o'clock in the morning. I live in Santa Barbara. It's, you know, God's waiting room for wealthy people. So this gal is like 82 years old. She has a full social life at Casa Dorinda, and she's really upset because she has a social engagement this afternoon and her lateral incisor broke off. Her dentist says, can you please just like cut a little temporary post hole? I know you won't find the canal, but something so I can put a paper clip in there as a temporary post. We can give her something aesthetic. So I saw her at noon, and we used dynamic guidance and found the canal 3/4 of the way up. And instead of giving him a temporary post hole, we sent the patient back at 1 o'clock with the root canal completed, the post preparation made, and the post size and fit ready for cementation by the GP. As an endodontist, that's an amazing service. You can do that for your patients. You're going to be very popular. The next topic I'd like to finish with is multisonic cleaning. This is using Sonendo's gentle wave cleaning system. And I've only done 4 cases, but I got to tell you, the 2 friends that I most trust clinically, Tom McClammy from Scottsdale, Arizona, Ryan Facer from Salt Lake City, Utah. These are some of the best endodontists on earth, and I got them into using gentle wave before I did. So they have a broader experience base, but I've learned a tremendous amount from them. So I think I'm coming into the 4 cases I've done with a little bit more background than maybe some others. So let's just look at what I've seen so far. I think the proof of this is really in the fill. The proof is in the fill for how effective cleaning was. There's nothing difficult about filling a lateral canal. The difficulty is cleaning it out so you can put some filling material in there. So that's the fun part for me now, is looking at post-op obturation radiographs is just a total hoot. So we have a central incised, we have a second premolar here, 2 roots, subtle lesion. Again, we look at the CT, it's a big fat obvious lesion. We can even see maybe a distal lateral root lesion mid-root there. Here's the mesial angle with a conventional radiography. And we see exactly what's going on there. It has a rich network of isthmuses, lateral rung communications between the 2 canals. There may be 3 or 4 exit points. So bringing the Sonendo console in, and this being my first case, I used one of their anterior premolar procedure instruments. And here's the down pack film. You can see these are super small shapes. I used a 3D shaper file from Brasseler. Literally, it's like putting a spring in a root canal, so it enlarges to cut the root canal from its natural form to some slightly larger size. So I love using those with Sonendo because Sonendo cleans without you needing to cut a shape. This cuts a shape that's minimal and usually provides me with a nice enough path to fit a cone and make obturation easy. But look how diminutive, how utterly conservative this looks from the straight buccal approach. And when you look at the middle image there from the mesial angle in a conventional film, you see how complex it was and how tiny and delicate the apical anatomy is. The thing that turns me on so much with gentle wave cleaning is, for the first time in my practice, I'm seeing post-op results looking just like the CT reconstructions that I started with my research partner, Jean-Pierre Hebert, in 1989 to 91. We used to reconstruct these things and say, what would it be like if we could actually, treat a root canal more in its natural form? And now we have that capability. Less instrumentation means less opportunities for damaging the root canal system. We not only get the procedure to be simpler, the part that precedes and follows the gentle wave cleaning, but it's this is literally going to change every part of procedural endodontics. Here's a case in point. Upper molar, MB root, quite a bit of curvature. I look at the CT imaging. Unfortunately, there is a fourth canal there, but it's super faint. I can almost see nothing until I get to the middle of the root. So let's look at some video. I looked forever for this. The only time I've not enjoyed having a CT machine is when it tells me for sure there's an MB2 and I can't find it. So I'm using EDTA solution to help remove the smeared layer. That makes it much easier to see the dentin coloration as a map to look for MB2 canals. But I was told early on that gentle wave cleaning can actually help you find canals. And so this was the second case I did, and it was proof of that statement. Here's a CT view. I took a CT in the middle of the procedure. You can see my drilling is exactly on. And from this view, again, exactly on. And that's because when I did the initial gentle wave cleaning, when I couldn't find the canal, I did a gentle wave procedure about a third of the way through it, and then saw a little bleeding point that perfectly pointed me to the MB2 canal. It was present and clean enough for a little bit of blood to come out of it and indicate its presence. It was still too small to ever get a file into it. I never did make that happen. Here's the case finished. I couldn't get into an MB2, but finally figured out that there was a mid-root bifurcation. If we look in this image on the right, we can see a trail of bioceramic sealer coming out mid-root. Here's the close-up of that. Here's the CT mesial view. And this is a canal that is at least 5 millimeters long. I never got a file into it. The only reason I cleaned this was because the multisonic cleaning procedure is so thorough. And here's the fourth case I've done. I did this on Thursday this last week. It's wavy gravy roots, almost no pulp chamber, super skinny. You go into these cases knowing that it's going to be a torturous pathway to get to length. Distal view shows me the breadth of the mesial root. Obviously, there's 2 canals in there. Most of these have a huge isthmus space, sometimes 4 millimeters wide at the top by maybe 6 or 7 millimeters long. That's a lot. That's almost half of the canal surface in the whole tooth. So I'm really interested in how this helps us treat that. And here's the CT view showing it's even a little bit more curved than you can tell conventionally. No big surprise. Here's the mesial view of the mesial root. Here, 2 canals. They may merge. They may have separate openings at the end. Here's the distal canal. It's 2 canals that merge mid-root and exit as one. You can see the lesions there. Here's my light filter. I'm using the Sound Seal staging material. I'm going to flow it all over the access tooth, light cure it to set the stage for the place I need to put my procedure instrument during the gentle wave cleaning. Here's the staging form for the top. You coat that, put it onto the Sound Seal that you've already put on the tooth, light cure it, and you're most of the way there. So I do light curing around the edge of it. Then I use an Explorer as taught to me by my trainer. Very carefully tip this off. I want to make sure that seal stays intact on the occlusal surface. And at this point, I'm going to go ahead and do light curing again to make sure it's as stable as possible. Following the light curing, I'm going to take I use my LA access burr. It's a guided burr. I go in there and I cut the stage opening to match the access prep. Guided burrs are really great because they don't cut a bigger access prep. They just cut the staging material above it. It turns out it's really critical when you cut this that you don't leave any little fins on the sidewall of the access cavity, because that will encourage flow of solutions up and under the seal here. That right there there's a thin layer there. We've got to cut that off. So just angle your burr, make sure you hit the cavo surface, and get a little butt joint right there. It'll make it harder for the solutions to sneak underneath the seal. Take that off, and I'm ready to put the procedure instrument on. I've chosen a sealing cap that makes the right length of extension of the operating tip. I like to put a little bite block in there. I have the patient help hold the PI against the tooth. It's only 8 minutes to do full cleaning in all 4 canals. Here is the post-op cleaning. You can see those orifices look super, super clean. I've never seen pulp chambers this clean in 38 years of endo training. So this is changing. Multi-sonic cleaning is changing a lot about what we do before and after. You can see I'm able to fit 2 cones in the distal canal, 0.5 millimeter from length. In the mesial canals, I'm not even within 3 to 4 millimeters. So in this case, the apial anatomy is so tortuous in the mesial canals, I could get bent negotiating files there, but I never could fit a cone there. So I'm going to fill those with carriers. I know a lot of endodontists don't use carrier-based obturation. I think it's fabulous. It has a broader applicability than cone fit techniques. And basically, endodontists should use carriers when they can't fit a cone. So the irony of carrier use by endodontists is most endodontists think it's an inferior way to fill root canals. But the best case for an endodontist to learn about it is the longest, curviest, worst anatomic challenge they've seen in the last 6 months. Put a carrier in that and you'll find out the value of it. In the distal canal, I fit the canals. I'm going to do a conventional, a center condensation down pack, a continuous wave of obturation technique with elements free and system B plugger tips. Using the hand plugger to condense the apial down pack. Now I'm using down packing the adjacent distal canal. There are 2 canals that merge mid-root. Taking it out, condensing that, and now I'm ready for backfilling. I use the elements-free backfilling syringe. These are both cordless. They are the only cordless down pack and backfill units I've used that operate the same level, the same speed of heating as the fully wired corded units. Here are the 2 canals. The needle goes in place. We always wait 5 seconds before syringing because we want to heat the needle back up after it's chilled by touching the dentin. It needs to be 160 degrees. The dentin is 37 degrees. So put it in place, wait 5 seconds, and the gutta perch will flow better when you pull the trigger a little bit later. So I'm backfilled just short of the orifice space here. I'm going to put the needle back in the adjacent canal. 1001, 1002, 1003, 1004, 1005. Push the button. It starts syringing out the end. As soon as it backs the needle up, I bring the small end of the blue plugger. It's 0.7 millimeters. It fits because it's the same size as the needle in the extruder. I backfill to the orifice level and then cut off all the extra around the orifice with the edge of the plugger. And I have a nice smooth surface to put my post-endodontic restorative effort up against. Now I'm drying the canals in the mesial root. Because I'm using carrier-based obturation here, I'm going to dry the canals and then I'm going to coat the coronal half the canals with, in this case, I'm using BC Sealer, a heat-resistant form of that. And a little second application just for good form. And here comes a gutta core carrier in the mesiolingual canal. Take it out of the oven and break off the handle in the stop because it's always in the way if I don't. Take that off. Here comes the second one from the mesiobuccal canal. Put it in about 3 to 4 seconds is correct. Don't worry if it hangs up short of your measured length because in most cases it will have filled all the way to the end of the root canal. So I'm using the edge of the plugger to cut the shank of the obturators and check it out. Okay, so there are some days you look at post-op radiographs and you're just wondering how you can write the treatment report to explain how it looks. This one, you just go in your private office and dance like a little private hornpipe with nobody watching, and then go back and say calmly, you know, I think it's going to work out pretty well. I like to do air abrasion because really, once we've done multi-sonic cleaning and 3D obturation, there's no way that this can fail unless it's failed structurally. With guidance, we keep the access openings, we keep the coronal shaping small with multi-sonic cleaning. And so if I can air braid this dentin and put glass ionomer against the pulp chamber floor and the filling material in the orifices, this thing is impervious to leakage. And once it's impervious to leakage, you remove the most common cause of endodontic failure over the long term. So I air braid, I put glass ionomer, I put bonding materials, and I light cure this, and then finish up with a bonding composite core buildup. So when I think of any of these technologies, I don't think of them as separate tools. I think of them in the full procedural flow of root canal therapy. And I always try to remember that the new technology is first going to be brought into my practice, kind of having my feet on both sides of the fence, trying to reconcile it with the techniques I already know. I've got to have a frame of reference. I can't change everything at the same time, but know that as you take these new technologies into your practice, after the initial familiarization, you're going to find out how this changes the rest of your procedure. You're going to change the way you access, change the way you negotiate. You're certainly going to change the way you shape root canals, and our objective is it's going to change the way you obturate them as well. So of all these technologies, this one technology is changing the procedure of conventional endodontics more than anything I've ever seen in my 4 decades in specialty. So that's a special thrill to be doing it for so long and see anatomic results that I've never seen before. And these look like chromium CT imaging results printed off of 3D print. Here's the post-op. We can see the 2 canals, the distal root merging. I could never fit a cone because there's like 5 or 6 different curvatures in the apical, 2 millimeters in the mesial canal. So not only can we clean these spaces that we can hardly get a file through, we can obturate these spaces. As long as they got cleaned out, we can fill anything. So multi-sonic cleaning is really making obturation a lot more fun of the sport. 3 stages of new technology that I've experienced. And, you know, I'm just as maladroit in bringing new things on in my practice as everybody else. It's anxiety provoking. We really don't want to ever have any failures at all. So you have to accept failure when you do a new technique. But the first attitude is, oh, this new technology is ridiculous. And then, you know, I remember thinking about sawn endo. It's like, right, I'm gonna spend a lot of money for a cleaning device when all I need to do is buy $5 a gallon sodium hypochlorite. Then you find out a little bit more about it, and you find out, oh, well, actually, it's not ridiculous, but I don't need it. That's not for me. And then the next step is after you start using it, and then you look back and go, how did we do this before? So this is exactly the same experience I had with chromium CT, with every one of these technologies, actually except heads up. Heads up magnification was something that I got exactly right, but the rest of them, it takes a while. So be patient with yourself. We have some questions now, I believe.
Yes, thank you so much, Dr. Buchanan, for sharing all your innovations. That was a really interesting presentation. The first question that we have is, what is the learning curve for 3D microscope?
Virtually zero. If I tell clinicians who ask this question, have you ever used a computer video game? And they all say yes, of course. And it's like, well, did you watch the controller or did you watch the TV? And this isn't any different. The controller is your hand and the handpiece, the tube. You can see better on the TV monitor than you could looking in your mouth. So the joke with heads-up magnification is, I really hate looking at people's mouths. I don't do that anymore. I just look up on monitors. It's really hard looking at the mouth. Oh my God, it's so small. It's such a weird place. It's always the wrong angle. It's never the right angle. I can sit a patient up in a chair, have 3D heads-up system, and not look in there at all, and operate totally blind with a perfect picture of it. So no, that one, extremely short learning curve.
Okay, second question. Do you find guided surgery necessary for all endodontic procedures or just specific types of cases?
No, if it's got a pulp chamber, you only have to drill 2 millimeters to find it. So unless it's a case where I'm trying to do absolute minimally invasive, I'm going to have a separate opening into the pulp chamber for each of the canals. I'm still experimenting with it and finding out what the limits are and where it's practical to use, but obviously calcifications are the most obvious, the greatest benefit of this technology.
Okay. Is the primary value with 3D microscopes improved ergonomics, better field of vision, or both?
Oh, both. The reason that microscopes haven't been popular in general dentistry is because they require a wider range of position of the magnification device. With endo, we're looking through little tiny access openings, so we can have a limited range of motion, and it still works. And the evidence of that is every endodontist in the world has at least 2 microscopes. Only 1% of the GPs have microscopes, and I think heads-up magnification is going to change that for them, because you can literally put the magnification camera over their body and aim it back up. You can put it on the side. You now have a 180 sphere of position you can potentially place it in, because your body's still in the same position. You're just looking straight at the monitor. It doesn't matter if they're standing on their head. You can see it.
Gentle wave question. How has gentle wave changed how you treat patients?
It's changed. Well, the easiest, most straightforward answer is when I finish a shape, I'm 8 minutes away from being completed. So before, it was I finish the shape and I have 30 to 40 minutes of irrigation time. I need to kill all the bacteria in a root canal with conventional irrigation systems. Now I finished the instrumentation. It's like, okay, in 8 minutes we're going to be ready to fill. You better start heating up the backfill gun. So that's really awesome. And then you start seeing, like the upper molar case, you start seeing different applications of it, and I can't find them in B2. Let's do a gentle wave partial procedure, see if it'll open up the orifice. It happens all the time. So it's helping me access and find canals. Well, the most 100% failure you'll ever have in an endodontic procedure is if you miss a canal. There's a lot of things you can do that will often work out in spite of you operating a little less than perfectly. Miss a canal, they all fail. So this is a huge help in that regard. In today's day of popularity of implants, people who do endodontics especially, we need to build a case that this tooth is worth saving. It's got enough structural integrity after root canal therapy to be not a temporary treatment plan for an implant, which is the implant surgeon joke, that we can make a smaller access, we can make a smaller coronal shape, because this cleaning capability is so tremendous. You don't need canal shapes like we did before when we used irrigating cannulas. We just need to clear a path to the root canal, so we know there's no calcific obstructions, and gentle wave will do all the rest of the cleaning. So, the final answer to that is, I don't know all the ways it's changing my procedure. I'm discovering that now, but it's already profound.
Well, the next question is related to this. Isn't this just an over-glorified irrigation device?
Some of the critiques of new technology are often just based on the fact that the individual making the complaint just doesn't know how to do the ROI calculation. We thought Chromium CT machines were ridiculous, because who's going to spend $100,000 on an X-ray imaging machine? Until a couple of us who had business degrees figured out that you're going to not only pay your lease every month from the fees you charge, and I added up mine over 6 years, I made $400,000 off my CT machine. So it's not the amount that you're spending on it, it's what you accomplish with it. And if we look at taking either a 2-visit procedure because they're not willing to irrigate long enough, or they're doing single-visit procedures like me and they're spending 30 to 40 minutes, my time's worth $1,000 an hour. So you save 20 to 30 minutes of my time taking a 40 to an 8-minute procedure. I'm making money every time I use it. So I guess I don't even look at it as, it's not an irrigating device. An irrigating device is something with a needle that you suck the solution or dispense it with. It's not an irrigation device. It's a cleaning system that really does actually the most important part of the procedure. We always get all hung up on the obturation, and we want to show this beautiful look. But if you kill all the bacteria in every root canal you ever treated, you could put glass ionomer at the orifice levels, not fill any of the root canals, and most of them would heal. So we see the evidence visually with the fill, but the most important thing is what precedes that. The only reason you'll ever see a lateral canal filled is because somebody cleaned it out. And we're seeing anatomy so complex and such a broad range of variation that it's reinventing. It's really, actually what it's reinventing is the look. We always talk about the Schilder technique, having this full access and this full coronal shape. We loved it because it meant that the management at the end of the root canal was the best it could be at that time, but that's when stainless steel instruments, none of our condensation devices were flexible. And so as we improved that technology, that look became obsolete, and younger endodontists became worried that if if they're prosthodontic referrals, they're the best you can have as an endodontist. If they think we're weakening teeth and they're going to send it to the implant surgeon instead of us, we got a serious problem. So they took on early on the campaign I've been working on for 30 years. It's like we need to get smaller access cavities, we need to reduce the coronal shapes in our canals. That's why I designed GT files with a maximum fluid diameter limitation, so it only cuts to 1 millimeter and then it stops enlarging them. These guys get this. So the new look became these little skinny shapes, which were beautiful in their conservatism, but I never saw lateral accessory canals filled. Now, the final evolution of this new look in endodontics is very, very small shapes with remarkable anatomy stressed in the fill factors. And that is going to be the new look. The new look is tiny shapes, maximum complexity of cleaning and filling. So that's, I don't know. I've been doing it for a long time. I haven't had as much fun.
What has impressed you most about the GentleWave technology? I was going to ask if that was what impressed you most, or what has impressed you most about GentleWave technology?
The thing that's impressed me the most is that the guys could even do what they said they were going to do. I spent a year listening to their riff about what they were accomplishing with multisonic ear cleaning, and you know, I'm just sitting there going like, this is ridiculous. You guys are making stuff up. You spend too much time near Silicon Valley. The most amazing thing is finding out they actually can do all the stuff they said they could do.
Excellent. Well, thank you, Dr. Buchanan. We've run out of time today, but if you've submitted a question, if any of our listeners have submitted a question and we did not get to it, we will answer it after the webinar via email. Please be sure to take the free CE quiz associated with the webinar. And shortly, we will send you a recording of this presentation and instructions on how to access the CE quiz, or you can access it on our endopracticeus.com webinar landing page. Thank you all again for attending, and a special thank you to Dr. Buchanan for an amazing presentation, and our sponsor for this webinar, Sonendo. Thank you, and have a good evening.
Good night.